afternoon and good evening to all our speakers, chairs, and the wonderful audiences of the ACNS webinars in different parts of the world. Welcome back to yet another session of very informative lectures for you. The speaker for the first session of today's webinar is our honored guest from India, Professor Rajneesh Kachra. Professor Rajneesh is a director at the Institute of Neurosciences, Medanta Super Specialty Hospital, Indore, Madhya Pradesh, India. He is the current president of the Skull-Based Surgery Society of India and Neurological Society of Indore. He is also the member of the Board of Education of Neurological Society of India. He was a previous associate professor at the Sri Chitra Tirunal Institute, Thiruvananthapuram, India. He is a noted author with several international publications in peer-reviewed journals, book chapters, and a number of international conference presentations. We are extremely honored to have him today at our webinars, and today he will be talking about perioptic meningiomas, surgical approaches, and visual outcomes. The speaker for the second session of today is our honored guest from Nepal, Professor Praveen Shrestha. Professor Shrestha is the president of the Nepali Society of Neurosurgeons. He is the chief of Department of Neurosciences, BNB Hospital, Gwarko, Lalitpur, Nepal, as well as senior consultant neurosurgeon at the Norvik International Hospital, Kathmandu. He was a past general secretary of the Nepal Epilepsy Society and he is the current chief editor of the Nepal Journal of Neurosciences, which is the official journal of NESON. We are extremely honored to have him today at our webinars, and today he will be talking about spinal schwannomas. The chair for the first session of today is our honored guest from Tokyo, Professor Akihide Kondo. He is the chairman and professor, Department of Neurosurgery at the prestigious Juntendo University, Tokyo, Japan. Professor Kondo is an expert in the management of brain tumors and is a very prominent figure in the Japanese Neurosurgical Society. His research interests are focused upon skull-based surgery. He has published several manuscripts in various international peer-reviewed journals, and we are extremely thankful to him for accepting an invitation to chair the session of Professor Rajneesh Kachra. The chair for the second session of today is our distinguished faculty from India, Professor Sajesh Menon. Professor Menon is the chief of Department of Neurosurgery at the Amrita Institute of Medical Sciences, Cochin, India. His clinical practice includes spine surgery, which includes degenerative diseases, deformity, tumors, infection, and trauma. He is a noted speaker and an invited faculty to various workshops and conferences in the country. We are extremely thankful to him for accepting an invitation to chair the session of Professor Praveen Shrestha. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato, I would like to welcome both the speakers and chairs to this online platform of ACNS webinars. A very warm welcome to our viewers from China, and we are extremely thankful to Professor Shubin for broadcasting this on the WeChat channel. Dr. Liu Bun Singh from Malaysia is my co-host for today, and with that introduction, I would like to hand over this podium to our first chair, Professor Sajesh Menon.
Very good evening to everybody. We'll start the first lecture, that is the spinal schwannomas by Praveen Shrestha of Nepal. He will be talking about the newer nuances and the development, current concepts and of management of the spinal schwannomas. So I invite you, Dr. Praveen, for your presentation.
Well, thank you very much, Dr. Menon. Okay, good evening, everybody. Professor Kato Sensei, Professor Shu Bin, the speakers and chairpersons of this session, all the seniors, colleagues, and all the members of ACNS. Once again, warm greetings on my own behalf from my place. I am Praveen Shrestha from Kathmandu, Nepal. And today I am really thankful to ACNS and the organizing committee of this webinar for giving me this opportunity today. Today I have made this presentation about spinal schwannoma in a very simple way. And I would like to dedicate this presentation today to all the young neurosurgeons of the world, not only Asia or my place, especially those who are willing to take up the spinal surgery as their future neurosurgical career. So I have made this presentation in a very simple way. With relatively a short notice, I tried to prepare it in the best possible way that I could. And in this presentation, I have tried to review a few of the basic theoretical aspects of schwannomas. I have also tried to review some of my experiences, and also I have tried to review few relevant literatures. With this note, I would like to start my presentation today. It may take around 40 minutes, so please kindly bear with me. To start with, these schwannomas, as you know, they are also called neuromas, neuroliomas, and neuromas. Sometimes interchangeably, they can also be, they're also called neurofibromas. Well, but there are basic histological differences between these two entities, schwannomas and neurofibromas. They are the benign tumors originating from the Schwann cells, and they are mostly found in the peripheral nerves, including cranial and spinal nerves. Most of them are solitary, that means they are non-syndromic, but some of them may be associated with NF2 neurofibromatosis. In this case, they are called neurofibromas, or they are also sometimes associated with NF2 as schwannomatosis. Well, clinically, they may present on the basis of one of these things, or maybe combined features depending upon the location of the tumor, size of the tumor, and local mass effect on the surrounding tissues and structures, and dysfunction of the nerve that they arise from. Well, they are said to be common in the age group ranging from 5th to 7th decade of the life. If they are associated with NF2, then they are found in more younger age group. There's no significant sex predominance, but some of the studies have shown that it is slightly more common in males, and this is similar to my own experience. Regarding pathology, according to WHO this classification, this is grade 1 tumors. They are benign encapsulated tumors. They arise from Schwann cells, and they grow eccentrically, not invading the parent nerve. And this is one of the differentiating point between neurofibromas and schwannomas. In case of neurofibroma, the tumor grows from the nerve itself. The KI index, KI67 index or MIB index is usually low, less than 5%, but if it is more than 5%, there's a tendency of regrowth if it is not totally excised. And these tumors are well differentiated, so the well differentiated eosinophilic schwannomas with basically two types of growth pattern, Antony A and Antony B. Antony A means densely packed cells, and they form the Verroque bodies, whereas Antony B is the less compact cells, and they tend to have more cystic degeneration in long run. But these are the, as you know, neurons, the axons, and the Schwann cells here. The tumors arise from the Schwann cell, grow eccentrically. And when they grow like this, pushing the nerve aside. And this is, as you can see in this picture, these are the compact cells, Antony A, and these are the loose cells, less compact, Antony B. Well, they present very typically in the radiological findings. Usually they are circumscribed, well demarcated lesions with local mass effect, but without any direct invasion to the surrounding structures. There can be cystic degeneration, especially if the schwannomas are bigger. There is more likely to have cystic degeneration and hemorrhagic changes. Hemorrhage may occur in 5% of the cases, but calcification is less common, but it is possible in case of schwannomas. In CT scan, they appear, CT scans are less sensitive and specific for the schwannomas, but they appear hypodense in CT scan. They enhance strongly with the contrast agent. And in case of larger tumors, because of these degenerative changes, degenerations, the enhancement may be heterogeneous. But especially this CT scan is helpful to see the bony structures, as you all know. There can be, because of the local mass effect, there can be bone erosion, sclerosis, or remodeling, which is more clearly evident in CT scan rather than MRI. But MRIs are more specific and sensitive for identifying the schwannomas. They appear isointense in T1 with a homogeneous enhancement, but in case of larger tumors with degenerative changes, the enhancement may be heterogeneous. And in T2, they appear hyperintense. And this T2 star sequence, MR sequence, shows the hemorrhagic changes if it is there. Regarding location, as I have already mentioned, this they may appear in cranial nerves, spinal nerves, or peripheral nerves. So in all these three groups of nerves, the schwannomas may develop. Total excision of the schwannomas are the surgery treatment of choice. And the parent nerve can be sometimes separated from the nerve itself, but it doesn't need to be separated all the time. Schwannomas are benign lesions, and they are completely curable if they are totally excised. Recurrence is usually is unusual if it is completely resected. And sometimes if partially resected or if left untreated, these schwannomas may undergo malignant changes, which is about 1.5 to 2% of all the tumors. These are the basic histological differences between schwannomas and neurofibromas. And these are the schwannomas look like this. They do not invade the surrounding structures and the nerves like this, but neurofibroma, it incorporates not only Schwann cells but also other cells like fibroblasts, other neuronal structures within the tumor. Well, coming to the spinal schwannomas, all the spinal tumors, they are much less common if compared to other CNS tumors. These spinal tumors, they account for about only 5 to 10% of all CNS tumors. And schwannomas are the most common spinal tumors, and they are the most common spinal nerve sheath tumors. And most of the schwannomas intradural extramedullary. If we look at the total intradural extramedullary tumors, schwannomas occupy about 50% of cases, meningioma 25%, others include about 25% of the total cases. Well, most of the schwannomas, about 70% of the schwannomas, they are intradural, and about 50%, slightly more than 50%, they extend extradurally to the extraforaminal space. And these about 50% are only extradural, and about 1% are intramedullary. And of total intradural tumors, schwannomas occupy more than 1/3 of the cases. Well, this is how the schwannoma develop. As you can see, this is the spinal nerve here. These are the ventral roots. These are the dorsal roots. Most commonly, these spinal schwannoma, they arise from the dorsal roots of the spinal nerve. And when we enter the spinal canal through the hemilaminectomy or laminectomy, then we readily see the nerve tumor like this. And we can also identify the dorsal root from which the nerve or this tumor arises. We can also find the motor nerve root, which has to be preserved. But if the tumor is big enough, then it comes out through the foramen to the extrafrontal space. In that cases, it may be a little bit difficult to dissect the tumor and identify the nerve of origin and motor nerve, but it can be identified. It has to be, these nerves they have to be identified, and they have to be preserved as far as possible. Well, regarding the location of spinal schwannomas, this is one of the biggest series of schwannomas with 367 cases. They have subdivided these schwannomas in different anatomical locations, like craniocervical junction, total 5% of the cases, cervical tract 23% of cases, in cervicothoracic junction 5.5% cases, thoracic tract 29% of cases, thoracolumbar junction 6%, and in lumbar tract 31.5%. So by this, what I mean to say is, even though the number may be different in different studies, different series, but grossly, more or less, what we can presume is that these schwannomas are almost equally present throughout the spine, in cervical spine, thoracic spine, and lumbar spine. They are almost equally, they occur throughout the spine. Well, clinically, as I've already mentioned, they arise from the dorsal sensory roots. So most common symptoms are the sensory symptoms, typically radicular pain and dermatomal features. Most of the time, there is no motor weakness, but of course, it may present with motor weakness if the motor nerve has been compressed, or if the tumor compresses spinal cord significantly, the patient may also present with myelopathy. There are several differential diagnoses of these schwannomas, most commonly meningiomas, paragangliomas, mixed papillary ependymoma, spinal dermal cyst. These are the main differential diagnoses. They sometimes mimic schwannomas in the preoperative MRIs. So we have to be very clear before surgery to identify the tumor properly, so that we can plan the surgery accordingly. Regarding this classification system, there are multiple classifications, and there doesn't seem to be any consensus among the surgeons which classification is the best one. It was the Caesar et al. Who first suggested classification in 2001. They classified it type 1 to type 5. Similarly, several other classifications, Gine and Komaya classification, but they didn't consider size. They considered only the anatomical location in relation to dura and spinal canal. Similarly, Park et al., they also followed the same classification as Sridhar et al., which was formulated by Sridhar et al., but additionally, they added this type 6 and 7, which are the more invasive schwannomas. Similarly, Asazuma classification, this is basically for the cervical dumbbell schwannomas. It is not used for the thoracic or lumbar schwannomas. They have classified into 9 types, type 1, 2A, B, C, 3A, 3B, 4, 5, and 6. All these are based on the anatomical location in relation to dura and spinal canal, and on the basis of the tumor size. Similarly, this is Sun and Pamir classification. They also have classified into different types based on the size and anatomical location. Whatever the classification system may be, this further classification modified by Park et al. This is the most commonly, this seems to be most commonly followed a classification system, because this system, as I have already mentioned, this system includes this more invasive type of the schwannomas. Basically, especially these type 5, 6, and 7, they are the invasive schwannomas which invade the vertebral bodies and which come out of the spinal canal to the extra foramen space when they become larger. Well, with this, some basic background of the spinal tumors, this is a small experiment that I would like to share with you all. Well, I just roughly analyzed about 2,500 cases of the spinal surgeries in last about 15 years. So among these cases, majority of cases, almost 3/4 of the cases were the degenerative spinal surgeries. Only 10% were the spinal tumors, and rest 15% were other kinds of the spinal surgeries. Among these spinal tumors, 1/3 of the cases were schwannomas, intradural or extradural schwannomas, and rest of the other cases were different cases. These are the different spinal surgeries we performed. And out of these, about 70 cases of spinal schwannoma, in our experience, it was slightly more common in males, 52% is to 48%, like other series that I have just now explained. We found it in a more common age group, 3rd to 5th decade. And then in our experience, it was more common in the lumbar spine, followed by cervical, and then in thoracic spine. We have quite a good percentage, I should say, because in previous series, it was about 5%, but we have around 8% of cases in craniocervical junction and about 4 or 6%, 4 cases or 6% in the thoracolumbar region. And in our experience, these lumbar schwannomas, almost all the lumbar schwannomas were intradural. Hardly few cases in lumbar spine were dumbbell or extraforaminal schwannomas, whereas almost all the dumbbell tumors that we had in our experience were cervical, in location more commonly in the cervical and in thoracic spine. Well, few experiences I would like to share with you all. Well, especially for the young neurosurgeons, this is a very simple and simple surgery for this kind of tumor, because to start with, we should start with the simple cases so that you have a good outcome. Whenever you see a MRI of this kind of beautiful, homogeneously enhancing globular spherical tumor in the intradural space in lumbar spine, then the first thing that you should think about is the schwannoma, even though other differential diagnoses are also possible. And patient usually presents with the radiculopathy or sometimes local back pain. And when you operate this kind of cases with complete excision, patient becomes perfectly all right immediately after surgery. So at the end of the day, patient is very happy, you are also happy. And probably these are the tumors that you should start with in your career. Similar type of lesion in the higher spine, it is in the dorsal spine. Once you open the dura, you can see the tumor immediately like this, as if the tumor is ready to greet you, saying, hello, doctor, like that. And it's not that difficult. It's very easy to detect all around the tumor to identify the nerve of origin and also to identify other nerve fibers surrounding the tumor. And once you take out completely, there is a spinal cord pushed aside, and usually there's no complication at all. You can sacrifice the nerve of origin, and other nerve fibers, nerve roots, they have to be preserved not to develop any post-operative neurological deficits. This is the patient after surgery with total excision of the tumor. Similarly, now you go up with a good experience in lumbar and thoracic spine. So these are the same type of, again, schwannomas in the cervical spine. Cervical spine is relatively more difficult because of the narrow space as compared to the lumbar spine. And moreover, we have to be very, very gentle in dissecting the tumors, and we have to be very careful not to damage the spinal cord itself. Otherwise, the outcome will be disastrous. As you can see, in most of the cases, we can do only just a hemilaminectomy like this. But sometimes when we leave this spinal process as it is, the space becomes very narrow. So sometimes what I do is I just take out the spinal process and leave the lamina as it is. It is hemilaminectomy without this spinous process, then it becomes much easier to identify the tumor here. And once the tumor is completely taken out, like this in post-operative MRI, the patient is again perfectly all right after surgery. Well, this is another type of the schwannoma that we had. As I had explained in the classification system, this is invasive type of, most like this is type 6 invasive schwannoma, which has invaded the vertebral body, and it has extended towards the foramen, but it has not gone beyond foramen, or it has not extended to the extraforamen space. In this type of lesion, simple laminectomy or hemilaminectomy may not be sufficient to visualize the tumor as a whole in totality. So in such cases, we have to go more laterally. In this case, we did the facetectomy on the same side, then identified the whole tumor. Like you can see, in the beginning, we had done simple hemilaminectomy. Again, I took out this spinous process, the opposite lamina is as it is there. And I had to, once I removed the facetectomy I did, then only I could see the tumor like this. In such case when we remove the facet, to avoid the instability of the surgery, then we do fixation, unilateral fixation like this. And so again, the patient is better after surgery without any previous symptoms. So in such cases, the surgical technique would be, in most of the cases, posterior approach is sufficient with total or hemilaminectomy and sometimes facetectomy. Once you open the dura, then tumor is usually readily visible there. And dissection of the normal nerve roots surrounding the tumor and nerve preservation has to be done with thorough dissection all around the tumor. The parent nerve root has to be identified, and most of the time it is not necessary to preserve this nerve root, the involved nerve root. It can be sacrificed without any significant post-operative deficit, because this is the dorsal root most of the time. This is the sensory nerve root, and it doesn't develop any post-operative complications. Before we take out the tumor, both the cranial and caudal end of the tumor has to be exposed. Once we have to see the tumor in totality before we manipulate the tumor, before we take out the tumor, because without seeing the tumor completely, it can be dangerous. We can injure the normal structures within the spinal canal. Well, again, the preservation of the nerve root can be attempted, but it is not always feasible and not necessary, as the involved nerve roots can be sacrificed without any significant post-operative deficit. Well, lamyoplasty is performed especially in children, especially if we perform multi-level laminectomy. But in majority of the cases, single-level laminectomy or hemilaminectomy is usually sufficient. Well, intraoperative physiological monitoring is very helpful and it is essential. But in our place, we started using this study neurophysiological monitoring only a few years back. Before that, we did majority of the cases without this neurophysical monitoring. Of course, microscope and micro instruments are the essential tools. Minimal invasive surgery can be performed. However, in our case, we didn't do minimal invasive surgery because the laminectomy itself with this open type is not that invasive, we suppose, with very minimal post-operative complications of the wound, as we have experienced. So we have not used this MIS technique so far. Sometimes we may need to fixate the spine, as I have shown. Well, this is another case of the young male. The tumor is like this at the level of T10 to L1. This was a bit confusing case. Before surgery, we are confused regarding the anatomical location. We are confused whether it has entered it is in the intramedullary space or intradural. Extramedullary, we are confused. And the confusion was what would be the possible histological type of this tumor, maybe myxopapillary ependyma, maybe schwannoma. We are confused. With this confusion, there was no other way to rather than going in. So we went in. As we had doubted, there were a lot of adhesion around the tumors. The tumor had extended to the intramedullary space, and finally we could take out the whole of the tumor in total. We could enucleate the tumor, and it turned out to be schwannoma of conus medullaris. But regarding intramedullary schwannoma of conus, it's a very rare entity. Most of the available literature are case reports, and till 2018, one of the article by this Ritika Singh et al., they had mentioned only 12 intramedullary schwannomas were reported till 2018. Intramedullary schwannomas, as I will mention, it is only about 1% of total schwannomas, and it is only about 0.3% of total intramedullary tumors. And most of the intramedullary schwannomas they are cervical and thoracic in the anatomical location, and this intramedullary schwannoma of conus is even much rarer according to literature. This is another small girl, as you can see, with the dumbbell schwannoma at the level of thoracic spine. Then we did the surgery again, trying to take out the whole of the tumor like this. And after the surgery, the girl is fine. The few technical aspects about this type of schwannoma in the thoracic spine is most of the time we can remove the tumor by this posterior approach, midline incision and laminectomy or hemilaminectomy. It is not that difficult to enter the spinal canal first, open the dura, remove the tumor as I had explained earlier. It is most of the time not that difficult. Regarding the extraforaminal part of this dumbbell tumor, then we have to do costotransfectomy to approach the extraforaminal space. We should not open the pleural cavity as far as possible to prevent the possible post-operative complications like pneumothorax or hemothorax. Once we take out the like this, once we take out this we do costotransfectomy, we can very easily identify the tumor and surround and dissect it from the pleural surface, and we can take it out very nicely. Once we remove the part of the rib like this, we have plenty of space to take out the tumor like this. So in such cases, we may need to fix the spine if multi-level laminectomy. In this case, this little girl, since we had only one level laminectomy, we did not fix the spine at that moment. But later, after about 3 years, this little girl, she presented again with slight scoliotic deformity of the spine, even though it was only one level laminectomy. Then I referred the case to my colleague for the corrective surgery because I didn't do fixation in case of small children. Well, these are other cases of spinal schwannomas. These are high cervical schwannoma, as you can see, at the level of the C1. These are much more difficult cases because the dissection of the tumor at this level is not that easy, and the outcome can be disastrous if we cannot take out the surgery tumor properly. If there is some difficulty in dissection, it can be really dangerous in this type of dumbbell schwannoma at the high cervical spine. But it is of course not that difficult. This was the around 55 years old lady, and then after the one level laminectomy, we could very easily identify the tumor like this. This was the tumor. This was the this intradural space after the complete removal of the tumor. And this is the post-operative MRI, which shows complete excision of the tumor. And the lady is fine after a few weeks of the surgery. Similarly, this was again a small boy presented with a huge mass on the back of the neck, like this, as you can see, with significant compression of the spinal cord and huge extraforaminal tumor. And in this case, the CT scan showed, as I have already explained, the erosion of the posterior rim of C1 and the lamina of the C2 like this. This is the hypotenuse lesion tumor you can see here. And this was the incision that we gave. We explored the subcutaneous space, which was full of multilobular mass. First, we identified the intraspinal part, identified the nerve of origin. We divided the nerve, took out the intraspinal part, and finally we took out the whole of the tumor. And this is this incision site, one site after the surgery. And this is the post-operative MRI. This is already almost 7 years after the. This was a few weeks after the surgery, but this boy is still under follow-up for last 7 years, and he has not developed any scoliotic deformity so far, and hopefully he won't develop later as well. Similarly, this is again another type of schwannoma at the level of C1, C2. Again, same kind of surgery. fine dissection around the nerve, around the tumor, and complete resection after the surgery, patient is fine. Well, in case of high cervical schwannomas, this again, in almost all the cases, we can approach the tumor with the posterior approach, laminectomy or hemilaminectomy. And sometimes far lateral approach may be indicated. In one case, we did partial fascicectomy, and that was good enough to expose the tumor and take out the tumor as a whole. We really need to be very, very gentle and for the dissection of the tumor. And the intraspinal part can be removed first, or sometimes, what I usually do in such cases, I do simultaneous dissection of the intraspinal part and extraspinal part, so that I can see the whole tumor at the same time. Then it becomes much easier for us to plan the surgery, to plan how we can remove the intraspinal as well as extraforaminal tumor. So then we can take out the tumor completely. Sometimes it can be problematic because of the venous plexus bleeding. Usually these venous plexus, they usually collapse because of the long-standing tumor with the local mass effect, but sometimes they may open up this plexus and they sometimes tend to bleed like anything. In such cases, simple compression with the help of cotton or gel foam for about 2 or 3 minutes will be sufficient, will be good enough to control this type of bleeding in most of the cases. And as I have already mentioned, in very few cases I have done fixation. Otherwise, no need of spinal fixation, as only one level or simple laminectomy, hemilaminectomy is sufficient for the removal of the tumor. So we have very few cases of spinal fixation, and there are no other significant post-operative complications. Even without fixation, there is no spinal deformity. Well, again, approach, and this is another case. Well, in this case, as you can see, this is a intramedullary tumor, quite a big one, extending throughout the cervical spine, spinal canal, very poorly enhancing lesion. Again, we are confused regarding its possible histological type. And this is the tumor, as you can see, multiple cystic components. And this is the post-operative image, almost complete resection, but there seem to be few, some small portion of the residual tumor possibly in this location, and histology came out to be intramedullary schwannoma. So again, this is another type of the rare schwannoma that we operated. This patient was quadriparatic with central cord syndrome before surgery. Even after surgery, this patient did not improve that much. And even after about 1 year after surgery, the patient is still wheelchair ridden and did not improve significantly even after surgery. So regarding our result, this is a small series, and in almost all the cases, total resection was possible, except in that case of intramedullary schwannoma. There's no recurrence in any of the cases because almost all the cases were operated, removed totally. There were no post-operative neurological deficit in almost all the schwannomas because this is very rewarding surgery. It's not that difficult to take out the tumor completely, and as a result, there is no additional neurological deficit until unless it is intramedullary tumor, intramedullary extension. And this is a relatively small experience as compared to other bigger series, but the more surgeries you do, more difficult cases will come. More difficult cases we do, more complications we may experience, and more varieties of clinical outcome we may have. So only on the basis of this result, we cannot be sure that in all the cases we have, we may have equally good outcomes. And regarding this neurofield monitoring, we started doing this only recently, a few years back. Well, now coming to the some review of the papers. This is the same paper that I had already quoted. This is this paper has really reviewed the historical aspects. They have reviewed the cases of schwannoma since 1951. That was the pre-CT era. That time they used to diagnose this type of tumors angiographically and with the help of myelography. CTs, they started using CTs in 1970s, MRIs after 1980s, and neurofield monitoring after 1990s. They are using this laminectomy and hemilaminectomy procedure for remove the tumor. And what they concluded and what they found was, despite significant advancement in the diagnostic and surgical tools, surgical technique basically remained the same. This is another article about minimally invasive surgery. They did this used minimally invasive surgery in and they compared this minimally invasive with total laminectomy. In minimally invasive surgery, they used muscle splitting approach using a tubular retractor and the unilateral laminectomy, preserving the contralateral paraspinal muscles and lamina. And what they concluded was safe and complete resection of intramedullary extramedullary schwannomas was obtained through the MIS approach, and they found it better than the total laminectomy approach. Regarding spinal dumbbell tumors, they have analyzed 647 different types of tumors, not only schwannomas, but different types of tumors. And in total, they found around 17.5% of the dumbbell tumors out of these 647 cases. And out of these 118 cases, 69% were schwannomas, and there were other neurofibromas, meningiomas, hemangiomas, and also malignant tumors. And they found the dumbbell tumors most commonly in the thoracic spine, accounting for about 44%, in thoracic spine 27%, and in lumbar spine 21%. The dumbbell schwannomas, the patients were relatively younger, and they found even the malignant dumbbell tumors more common in the children with the age below 10 years. And this is another article about what happens if the tumor is resected subtotally. They had reviewed 500 spinal schwannomas, out of which 59 cases had residual, that means taken out subtotally, about 12%. And none of those residual tumors underwent radiotherapy or radiosurgery. And 30% among those cases with residual tumors, only 30% had the regrowth. In about 5 years' time, the regrowth rate was about 1 millimeter per year. And they found that Ki67 is, of course, very important index, not only in case of schwannoma, but in any case of neoplastic lesion or in the human body. So similarly, this also Ki67 is very important in predicting the recurrence in case of schwannoma. In other cases, they found the Ki67 index 3.5%, but in the cases where it recurred, the Ki67 was more than 6.3%. So in conclusion, spinal schwannomas present in wide variety of locations with wide varieties of symptoms. And according to these locations, the tumor, the surgical procedure also varies. So we have to develop our knowledge and skill accordingly, according to the location of the tumors, according to the size of the tumors, so that we can remove the tumor in total. So this is very rewarding surgery if we can take out completely without any recurrence, and the post-operatively patient becomes much better. So it has to be, the action should be total. It should be total removal should be the goal, and it is almost always possible. And the involved blood route can be sacrificed without any possibility of post-operative deficits. In case of cervical schwannomas, the intraspinal parts are usually much smaller, so we can take out the intraspinal part much easily. But however, the dissection becomes, of course, much more difficult than in other locations, and we have to be very, very careful. And if possible, we should send Ki67 for all the tumors, especially for those where there is residual cases. In our experience, well, this immunohistochemistry is not a regular routine practice in our place. So whenever we have doubt, we send this Ki67, but we do not send it regularly. So in case of residual tumor, we have to follow the patients regularly so that we can manage the residual tumor. If it grows again, we can manage it promptly. Well, I think this is the end of my presentation. Once again, thank you very much for giving me this opportunity today. Thank you. Thank you very much.
Thank you very much, Professor Praveen, for an excellent presentation. And this paper is open for discussion now. Any questions, suggestions, or comment, please?
Can I just pass some comments? What an excellent paper teaching session, Praveen. We enjoyed your a couple of Sunday. What you told is, always cervical canal is more roomy than dorsal canal. Dorsal canal is most unforgiving. So you mentioned cervical canal is narrow, but they are more roomy than dorsal. And also you told one thing which I always teach my residents for any extraaxial tumor, whether it is in the brain or in the spinal canal. Say you told that one should coagulate over the surface. Never do that. Then you lose that arachnoid plane, everything. You peel the arachnoid, make a small incision, decore. Once you decore, you can keep on separating this arachnoid. And once you coagulate the whole surface, you lose that dissection plane. Especially here, you are more interested in preserving the ventral root. That is my comment. And third thing, you correctly addressed, told that more anterior, lateral, or anterior. You said you will do facetectomy to reach anterior part. And you showed in so many tumors which are more anterior, lateral, and not. One short, you told that you can sacrifice posterior nerve, especially if it is in the dorsal area. But more importantly, another trick is to cut the dentate ligament, and then you take a suture on that dentate ligament, and you can take a hitch stitch that will give more access to ventral area. This is my comment. Excellent lecture, Praveen. Enjoy.
Thank you, sir. Thank you very much. I fully agree with you, sir. Thank you very much.
We have Ben joined in from Hong Kong. Ben, any questions from you?
Yes, and good evening, and nice to see all of you, and congratulations on your great results of your spinal schwannomas. I encountered several giant thoracic schwannoma that a thoracic and a lumbar lumbosacral schwannoma that is quite massive, and they protrude extra foraminally into the retroperitoneal structures. So one of the difficulty would be the inferior vena cava and also the aorta. So for those giant cases, especially in NF2, would you cooperate with general surgeons, or would you aim for a gross total removal in such cases? Thank you.
Yeah, thank you very much, Dr. Bain. It's a very nice question. In case of a small dumbbell schwannoma, as I had shown, we can directly go to the surrounding space in the extraforaminal space by removing a part of the rib. It is not that difficult. But in case of giant dumbbell schwannoma with significant portion in the thoracic cavity with surrounding vital structures like vena cava and aorta, definitely I go with the my colleague thoracic surgeon. I take help from the thoracic surgeon because they are much better in dissecting this kind of lesion in that anatomical location. So in case of bigger lesions, I almost always ask my thoracic surgeon colleague to help me to remove the extraforaminal part.
And may I also ask, in such cases, do you usually go transabdominally or retroperitoneally, or you still go from posteriorly?
Well, so far in my experience, probably because it is not that big one. So far I have done almost all cases posteriorly through the posterior approach by lamyotomy and transversectomy. So in most of my cases, I have taken out the tumor in the same approach.
Thank you so much.
Thank you.
Liu, any questions from you?
Hello, Prof. Thanks for a nice presentation. I have two questions for you, Prof. Have you ever encountered that there's no clear demarcation between the spinal tumor and the spinal cord? In those situations, if you face, how you decide how you separate it from the spinal cord? My second question: have you ever encountered a risk of a CSF leakage from the resection of the spinal schwannoma, and how you reduce that risk? Thank you, Professor.
Thank you very much, Dr. Boone. Yeah, in case of extramedullary intradural tumor, most of the time, this is, as I have explained, there is not at all any difficulty differentiating tumor and surrounding structures. But of course, when there is intramedullary schwannomas, like I had shown, of course, it is very difficult to identify the tumor. Even pre-operatively, we can hardly differentiate, the tumor margin and the normal spinal cord tissue. Also, in one case that I have shown you in the conus medullaris, it was really difficult to differentiate. But as you know, in case of schwannoma, usually it is encapsulated, well encapsulated tumor. And as Professor Suresh was explaining, of course, what I do is after taking out the layer of the arachnoid, I usually coagulate the tumor with a bipolar, sharp one. And by coagulating the surface of the tumor, we can slowly shrink the tumor. Once it gets shrunken, then it gets slowly separated from the surrounding tissues. So, of course, it is not that easy to dissect it off the normal spinal cord tissues. But if it is really a schwannoma, then somehow we can manage the dissection and we can separate it much more easily as compared to like intramedullary astrocytoma, which is really difficult ones. So in case schwannoma, of course, it is difficult, but we can manage it if we dissect it nicely. And your second question was CSF leak. Well, of course, CSF leak is a possibility in any case of spinal surgery. Even sometimes, even in simple disc surgery, we can have CSF leak. Sometimes it can be really notorious, really problematic. And most of the time, I really have very few cases in which I had to go in and I had to repair again the leaking point. In most of the cases, it gets controlled. Especially in case of cervical spine, my experience is without any further repair, it gets controlled within 1 or 2 weeks. If it doesn't get controlled, then of course I put a lumbar drain for about 5 or 7 days or 1 week like that. And in most of the cases, it can be easily controlled with lumbar drain.
Thank you, Professor.
Thank you.
Yes, Ben has raised his hand.
Can I
Yes,
ask another quick question, Professor? And I want to ask, in your spinal schwannoma cases, do you routinely put a wound drain during the operation? And if you put the wound drain, which layer would you put the wound drain during your closure of the wound?
You mean drain?
Yeah, drain.
Drain. Okay. In most of the cases, I usually don't put drain. Because when in any surgery, when we open the dura and when we close the dura, I really hesitate to put the drain, because sometimes accidentally, it may shock the CSF from the intraspinal intradural space. In that case, there is usually possibility of CSF leakage, as our friend Dr. Boone has asked. So most of the cases, if there is no significant tissue damage, if there is no significant bleeding at the end of the surgery, usually I don't put drain, not only in this kind of surgery, but any kind of surgery. I really hesitate to put drain as long as it is really indicated. So I usually don't put drain.
I see. Thank you so much.
Professor Sajesh, any comments from you?
I think it is the MIS is a good option for this kind of small tumors. We can take it out with a small incision, and the patient will be really we can make ambulant and pain free the next morning. We started doing it with MIS recently, and it gives much more satisfying result than a conventional open surgery. Second point, I'm saying that at times, very rarely you'll get this neurofibroma schwannoma arising from the motor route. Sometimes you can get it. I have only once the same such one case where I had to, because I always do the stimulation of the nerve root before cutting it. If it is there's not there is no motor response, then only I usually cut it. Otherwise, especially in the cervical and as well as lumbar spine, that I think is a good practice. Even in once in 1,000 cases, if you get it motor deficit by doing schwannoma, that is still worthwhile in doing monitoring or stimulation. Other than that, I think is complete. Professor Praveen did a very remarkable job and touched every aspect of the Schwannoma in a very crisp and clear manner. I don't think any addition is required. It's
Thank you.
so nice.
Well, thank you very much, Dr. Praveen. That was an excellent presentation. If I may add one little remark that currently in the recent times, one specific prognostic factor which came into effect was the tumor occupancy ratio, where they measure the tumor size, and what the tumor size is like small a plus b, maximum longitudinal and axial, and divided by capital A plus B, that spinal canal at that level on the horizontal and axial plane, and into 100. And this was first mentioned by Anne et al. In 2007, and later recently from AIMS Raipur came out with a very good paper that tumor occupancy ratio, if it is more than 80 or less than 80, in patients who are less than 80 will have very good improvement in their gait scores post-operatively. So this is one just small thing I wanted to add. One peculiar question I would like to ask you about migratory schwannomas of the lumbar roots. Have you ever experienced when you open and you have not found a tumor? It is very well reported in the literature, but curiously I'm asking you.
Yes, sometimes it can happen like that, but fortunately or unfortunately, I don't know. In my series, I have not experienced. Well, I have so far found the tumor exactly in the place where we are supposed to have that tumor. So far, no, Dr. Raja, I have not encountered any this kind of migrated schwannomas.
That is extremely lucky for you and most of us.
Exactly.
Professor Sajesh, sir, have you had any experience?
The lumbar, it can happen, especially for a small schwannomas if you are dealing with it. If a sizable schwannoma, and it is, as you said, it will remain in the same place. But the small schwannomas, by positioning and the changing position, and sometimes you will miss it. You have to extend your laminectomy one level below and above to find it, and you can take it. That's possible, yes.
Yes, another question that, as you mentioned, that when you take out the facet, you fix it generally. But this opinion is also very much divided in most of the people. Last 1 week back, we had Professor Konvalov from Burtenko, which is the largest institute in Russia, and he said that he removes one or two facets in the lumbar spine but never fixes. So it is also like different people have different choices. But I would like to ask Professor Sajesh and Professor Praveen also, like scientific.
Yeah.
What is really scientific?
Yeah, I also have few cases in which not only in case of schwannoma tumors, but also in other spinal surgeries. Sometimes, we may need to take out the facet, and we may not fix the spine without any fixation. The patient usually they don't have any problem if the patient is not obese, if they don't have any, if physically they are fit. I also have few cases without any fixation, even after the facetectomy, patient does well and they don't develop any other instability problems. So to some extent, I think I should agree with that professor from Russia.
My views are totally different because I always fix it whenever the facet is violated. This thing is my surgical technique is to fix it because I don't want to leave or another surgery, because I have seen few patients with the instability developing, not from other surgeons who does without fixation, and then patient can develop instability and pain. So I think maybe this is a personal choice, but if you can do it, I think I will recommend fixation rather than leaving the patient like that.
Yes, definitely.
That is a point well taken. I think we have come to the end of the first session, and I would like to ask Professor Sajesh Menon for his concluding remarks.
Probably this is one of the first session I actually attended for this CNS. And it is I really appreciate this session, and I really thankful for you to calling me. And now on the session went very well. The discussions was very fruitful, and so. Next time onwards, I will be there for all this presentation. That's all I can tell you. Thank you very much for inviting me for this.
Thank you very much, Professor Sajesh Menon and Professor Praveen, for this wonderful lecture.
Thank you.
And beautiful first session. And thank you all the panelists who joined in. I would like to mention that this is being broadcasted on WeChat, YouTube, and Zoom. And as of now, we have around 560 people who have joined us live from on different platforms. I would like to invite Professor Akihide Kondo to say a few words of introduction and invite Professor Rajneesh Kachra for his lecture. Professor Rajneesh Kachra, I hope, yes sir, you are back. Thank you very much.
Yeah, I'm back.
So, Professor Akihide Kondo, please.
Yes, this is Kondo from Japan, and good morning or good evening or somewhere. But really nice to see you guys. So today we have the Dr. Kachra. And you may know that Dr. Kachra is a very famous neurosurgeon in India, and he has tons of experience about the skull-based surgery, and including the vascular surgery and the tumor surgery. And I think that his lecture is titled about the Perioptic Meningiomas and microsurgical treatment and the visual outcomes. And I hope that we can get something from his lecture, because since he has tons of experience about this type of the surgery, so I totally expect that we have something from him. So Dr. Kachra, please start your lecture.
Yeah, first of all, I must thank Professor Yoko Kato and Chairman Education Committee, Dr. Raja and his team for inviting me for this ACNS webinar. It's an honor and pleasure to present in this ACNS webinar. And my topic today is perioptic meningioma, microsurgical management and the visual outcome, particularly how the vision we can improve on these meningiomas. So this topic is, is very close to my heart. And many times we have analyzed these tumors, and I will quickly go through the topic. Yeah, the perioptic meningiomas, the area is this one in relation to the enteroclinoids, optic canal, and the carotid. So the optic nerve, both sides, and the carotid artery and all these bony structures constitutes this area. And the tumors arising from this region, most common is tuberculum sella, clinodal meningioma, diaphragm sella, and planum sphenoidal meningioma. I will be discussing in detail about the tuberculum and the clinodal meningioma. And this is mostly my part of my talk. The surgical goal in perioptic meningioma, as you know, the optic nerves and anterior visual pathway, very, very delicate structures. And these are all surrounded by the very important blood vessels, third nerve. So it's a very complex area. So the surgical goal has to be a complete removal whenever possible, and the preservation, or if not improvement, at least we can preserve whatever vision is there in the patient, and avoidance of the surgical morbidity and mortality, because there are so many important vital structures all around this area. Well, difficulties for removal of removing these tumors totally. There are problems. There are difficulties because of the delicate nature of the optic nerve. See, the normal optic nerve can sustain some kind of manipulation when you operate, but a diseased nerve cannot sustain a minimal manipulation also. So you have to preserve these structures. Then there are major blood vessels in the vicinity, those you have to take care while dissection, so that it should not cause any catastrophe while drilling, while dissecting the tumor, right from the carotid to its bifurcation and middle cerebral arteries and intercerebral arteries. These are all there in the vicinity. Of course, you have to control the tumor blood supply, tumor extensions you have to see, and the bone involvement. All these things has to be taken care. So this is our experience of operating about 70 out of that 36 for tuberculum meningioma. Now it is 37, and medial sphenoid meningioma out of that clinoidal were 25 and sphenoid were 7 patients. And there was one case of diaphragm meningioma. Then we come to tuberculum meningioma. As you know, the tuberculum meningioma, they arise from this ridge that is called tuberculum and the chiasmatic sulcus. These are the two most important structures from where this tumor arises. It can extend anteriorly to get attachment from the planum, or it can go posteriorly and down to get some attachment from the diaphragm. And tumors can extend laterally, and it will cause displacement of the optic nerves laterally and optic chiasm either posteriorly or superiorly. And the tuberculum meningioma, they constitute about 5 to 10% of all the meningiomas. And if you take anterior skull-based meningiomas, about 40% tumors are the anterior skull-based meningioma out of the all meningiomas. And amongst that, the tuberculum meningioma is about 25%. And this is, as you know, for all meningiomas, the females, they outnumber the males. And this tumor is common in 4th, 5th, or some series in the 6th decade also. These tumors, why important are, they tend to involve the optic canals, and tumor can extend inside the optic canal, and that has to be clear to get the good visual outcome. And you see this diagram, usually they start at the junction of optic foramen, this off the midline. Usually these tumors start off the midline. They catch the one side of optic nerve. So the patient will present with a unilateral visual loss. And then once tumor grows to a larger size, it will involve the other side nerve. So majority of the time, patient has got a bilateral visual involvement. This is the most common presentation these patients present with. Initially, as I told you, the unilateral involvement of the optic nerve, which will cause unilateral visual loss. Then once tumor grows a large size, it will involve both sides. By the time the first side, the other side, they may become many times blind. So many patients, they become unilaterally blind, and other side is very significant involvement of the vision. And many times these patients, they present with a chronic headache. There is about 40 to 50% of the patient, they can have headaches. They can present sometimes seizures. They have bitemporal field loss. When tumor grows to very large size, it can cause the frontal lobe syndromes. They can have change in their personality, their behavior, their lack of motivation. They may have apathy. They may have depressed mood and short-term memory changes. How to work up these patients? The clinical history and examination is the most important. Then you have to go for the visual field and the acuity charting. How much is the preoperative visual loss in terms of the acuity and in terms of the visual fields. Then you have to go for the MRI brain with contrast, with a thin slice, with no interslice spacing, which is very important to identify any tumor extension inside the optic. Cerebral angiography, it is not necessary, but for the larger tumors, it can be done to see for the vessel displacements, but this can be very well, now we can get information from the MRI angiography also. So coming to the approaches, I will be talking mainly the transcranial approaches. And these are the various approaches can be used to tackle these tumors. But in our series, we have used mostly the pterional craniotomy for the larger tumors, frontotemporal craniotomy. Or nowadays, many tumors have operated by a small frontolateral craniotomy. This is gives a very good access for these tumors and gives a very shortest distance to reach this tumor and clear this tumor. Sometimes tumors are very large, we may have to do bifrontal craniotomy. Orbitozygomatic osteotomy can be added in this. Now, supraorbital mini craniotomy also being used for these kind of tumors. Then, very much now in vogue is now endoscopic endonasal surgery through the transsphenoidal route. It can be done endoscopically or it can be done microscopically. I will go through some of the examples. This is the one lady about 50 years old. She has presented with the left side visual symptom. And you can see there is some tumor which is extending inside the tumor. And this is the old tumor extensions. Mostly it is attached to the tuberculoma. And we'll see the video now. This is a longer video, particularly for the younger colleagues, younger neurosurgeons. So we go, this is a frontolateral approach. This is a small part of the sigmoid fissure is only exposed. And you can see all the structures here. This is on the right side. And I always go from the right side, whether whatever vision loss is more or less on that particular side. But because for a right-handed surgeon, I think it is very, very important. And right side vision, if it is good, that nerve will tolerate minimal handling also very nicely as compared to the diseased nerve. So we go for the maximal decompression of the tumor so that make the tumor volume less, tumor capsule very floppy so that it can be separated with minimal manipulation from the surrounding structures. So the decompression and the devascularization should go simultaneously and make the tumor very small so that it can be separated very well from the surrounding structures. Now, once tumor is made very small, then it can be, you can separate the capsule and go for the attachment. So you can see it's a small craniotomy, just frontal lobe laterally is retracted, temporal lobe is not seen even. This slightly longer video, I think it will be nice for the young users to see. So once it is very thin capsule, very small volume of the tumor, now sharply, dissecting from the chiasm. This is optic chiasm. This is very well decompressed right optic nerve. This is carotid artery. As you cut this arachnoid bends, tumor lobules come into the view, get separated from the surrounding structure automatically once it is decompressed so well. Now this is separating from the pituitary stalk, very sharp dissection. This is very nicely seen pituitary stalk. Pituitary stalk has got a very good arachnoid around it, and in our series and whatever series I have analyzed at Chitra Institute about suprasellar meningioma, none of the patient has got any hormonal disturbances. Usually they don't have this, like in pituitary adenoid. So now this is the left optic nerve. His tumor is being separated from the left optic nerve, and patient has got a visual deficit only on the left side. And as I showed you in the MRI, there was some suggestion in the MRI, there is some involvement of the optic canal. So sharply dissecting arachnoid bands from the left optic nerve. And for that extension of the tumor in the optic canal, it is very good to do from the right side for the left side optic canal. You can visualize very well. So this is good for this patient also to operate. This is the optic nerve here. Now this is clearing from the optic canal. This is optic nerve here. You have to have a very low setting for the bipolar to coagulate in this area. And you can see here, this is the midline. And you see here, there is no attachment. His tumor arises always from the one side of midline. So this tumor is mainly attached on the left side, and it has it has involved the left side nerve in first, and there was no symptom of visual symptom on the right side. So this now tumor, small tumor at the attachment only is remaining, and maybe small part of the tumor on the undersurface of the. Now you see, I am just scooping out at whatever part which is seen under that. Sorry. So that part has come out. So and nerve is completely free. So this is the end. This is the only attachment. So the tumor was extending so much on the sides and posteriorly, but the attachment is very, very discreet here, only on the one side. Very, very small attachment. Rest of the other places is not having any attachment. So while cutting here, one has to be very careful. There may be some bleeding from the attachment area. But sometimes you may have bleeding from the some carotid perforators also. And that's how at the end we excise this attachment area. The bleeding was mainly from the attachment area, and it is not controlled. So this is complete excision of the tumor. And at the end, you can see here, this is the dorsum. This is pituitary stalk. And this is the post-op MRI of this. Complete excision of the tumor, and patient had a very good day. This is a post-op MRI which showed the complete excision of the tumor. Small video. This is a classical T-renal approach we have taken in this patient, and opened the cilium fissure and on the tumor now. Again on the right side, eye approach and maximal decompression of the tumor. Sometimes these tumor extend to the ACF floor also, to the planum. very nicely decompressed nerves on both sides. This is pituitary stalk again. It is very well preserved. This is another case of tuberculum meningoma. This lady who was present with the left side blindness, and this patient again we have operated with the same frontolateral approach. The left side vision is poor, not having any vision, but I again went on the right side. The right side, even if we try vision for the left optic nerve, some improvement if it comes, that with the minimal handling also that disease now will lose the chances of vision. So I always go on the right side. Right side nerve is a better nerve. It can sustain some amount of manipulation very well. You can see the very thin papery nerve on the left side, left optic nerve. The right side nerve is very good caliber, very good vascularity. And this arachnoid is most important to preserve and dissect arachnoid to sharply to separate these tumor from the surrounding structures. This is at the end. You can see the basilar artery here. Another case of this is post-operative CT scan shows complete excision of the tumor. This patient had a tumor which was extending into the optic canal on the right side, and she was blind on that side. I will show a small video. In this case, we have opened up this optic canal. This is optic nerve sheath here, and this was a must to open the optic canal to remove this tumor. The patient was blind on this side, right side. This is a very old case, so the video quality is not that good. I apologize for that. This is other side optic nerve. This is this side optic nerve. You see, when it is compressed by the tumor, which is extending inside the canal, now becomes so gliotic. And even if you, whatever you do, extradural clino drilling or optic canal decompression, the disease nerve, which is very thin because of the tumor pressure, may get demyelinated or gets ischemic because of the tumor compression, and usually they do not improve in spite of decompression of the optic canal. You see the tumor is being removed from the optic canal. So nerve is preserved here, but you see the nerve caliber is so thin, vascularity is very poor. This is another case who has got a very poor vision in both eyes and got operated, and she has improved the vision. You can see the one eye is almost normal, other eye is also improving very well. So this tumor surgery is very rewarding in terms of the visual function and following surgery. This is another tumor which was operated long back, and sometime this very tubular vision patient had in the bilateral, very, very poor vision. And after tumor surgery, subsequently started improving. At 1 week's time, we regularly do this visual charting at 1 week, after 6 weeks, and at 6 months. So the patient has improved vision completely. This patient was operated at Sri Chitra Tirunal Institute where I was working earlier. This is one interesting patient who has presented with the minimal visual symptoms, and this was being operated by another surgeon, and he thought it's a pituitary adenoma and positioned as transfemoral surgery. But when I was called, I thought it's not a pituitary adenoma, it's a because of the broad base here. And this patient we had operated through microscopic transfemoral surgery, And this is a post-operative MRI which shows complete excision. And this is a CT scan is area of resection. The problem is here, the repairing for the defect to avoid the Csf leak in this. There are another cases, some of the patient can have this hyperostosis of the tuberculum. And this another patient who was operated earlier, this is showing complete excision. Another case, this post-operative MRI showed complete excision. This lady also again operated by the same route, our unilateral frontolateral this planum and tuberculum, and they grow to very big size to involve the visual and give rise to visual symptoms. And this is one such patient operated. This is the post-operative CT scan showing complete excision. Yet another case with the complete excision of the tumor. This is the last patient which I had operated very recently, not very recently, about 6 months ago. This patient had a visual symptoms with tuberculum and also has got a high-grade glioma. Both the tumors were excised in the same sitting. So, based on our series, we have published this this article in this paper with emphasis on the visual outcome. This article is due for the printing already in the press. So, number of patients we had analyzed in this series were 36 and females were 27. 9 were male. The median age was 48 years, and for the female it was 48 and male 50 years. And main clinical symptom was the visual deterioration, which is seen in about 90% of the patients. Headache was seen in about 50% of the patients. Seizures in 2% of the patients, and behavior changes in 5% of the patients. We had analyzed the visual outcome by this grading scale of WHO, which shows the grade 0 is a good vision or very mild impairment, and grade 5 is the blindness. Coming to our series, so we have made into 72 because many times one eye will be blind and other eye some visual involvement. And the blind eye doesn't improve. The other eye vision improves. So how to categorize this? So we have divided into 72 eyes. Which eye has improved, which have taken into the consideration. So on the right side, this is on the right side. So 6 patients had a very minimal involvement and 10 patients had a very severe involvement of the vision. On the left eye, 4 patients had a grade 0 or very minimal involvement, and 8 patients had a very severe involvement. Coming to the vision outcome in these patients, on the left eye vision, 19 patients remained status quo, whatever their vision on the preoperative scale, it was remained static. But in 13 plus 2, 15 patients, there was improvement by 1 grade and 2 patients by 2 grades. We had a 2 mortality in this series. So on the left side, this 15 and 19, 34 patients had either a preservation of vision or there is improvement by 1 or 2 grades. Into the right eye, in the right eye also 17 patients had a status quo vision and about 15 patients had an improvement in either grade 1 or grade 2. And this is as compared to other series. We had a 36 patient with 72 eyes. Visual impairment was seen in the 90%. Headache was there in the 50%, and 5% patient had a behavioral changes, and about 3% patient had. Our gross resection rate was about 94% in this patient, all transcranial except 1 patient was operated with the transcranial. And improvement of vision was seen in about 31 eyes, and it remained static in the 35 eyes. There was a deterioration in 2 eyes because of the surgery or whatever reasons. Now we come to the clinodal meningioma, another perioptic meningioma, which has got a significant challenge to remove these tumors. Clinodal meningioma has got gives surgical significant surgical challenge due around the anterior process, that is in the optic nerve, very delicate structure, and it involved because of tumor. And Professor Lamyoplasty in his article, which is he has described this meningioma in very great detail. In 1990, he has said the clinodal meningioma are second only to the clival meningioma in surgical mortality and morbidity rates, and failure of the total removal and high rates of recurrence. Anterior clinodal meningiomas are considered different from the meningiomas of the middle spinal. Here in clinodal meningioma, there is a very discrete involvement of the anterior clinode process, is not same as the medial sphenoid meningioma, and you will see a hyperostosis only involving the clinoid tip. The incidence of these tumors is less than 10% of the supratental meningiomas, and amongst the sphenoid meningioma, if we take about for 35 minutes, you see this area is this this clinoid here, and this is carotid artery. Superomedially, it is optic in relation to this, and we go more laterally. This is the so, and medially here is the pituitary stalk and the dorsum here. So, a region which is having so many excising these tumors with minimal morbidity and expecting a good visual outcome is a challenge to operate these. Clinodal meningioma has been variously named as either deep inner third of clinoid or anterior clinoid meningioma. When they grow to large size, sphenocaverous meningioma also has been term given to this meningioma. And they can involve the lateral wall of the cavernous sinus. It can go posteriorly to involve the when they grow to a very large size. They have tentorial attachment, and these tumors are really very challenging. This is the diagram which I have made in my, I had a skull specimen, and this is my understanding that these are the tumors, clinodal meningioma. They arise from this part of the clinoid and under surface of the clinoid process, and this near the optic foramen. So this area give rise to this very important type of meningioma, which can involve these structures around and pose a difficult challenge to remove this tumor. Lamyoplasty had classified these tumors in three varieties: group 1, group 3. Group 1 meningioma usually gets origin from the undersurface of the clinoid, and usually it involves the part of the carotid which is intradural but doesn't have arachnoid. And this type of the tumor, because there is no arachnoid, where these tumors, they can involve the carotid wall, and these are very challenging tumor to excise these tumors completely. Sometimes you have to leave some part of the tumor there. And group 2 tumors are good tumors, and usually they arise from the superolateral aspect of the clinoid process from here. And usually many times these tumors may not have a good may not have a very significant visual symptoms. And as you know, the clinodal meningioma have a unilateral, tuberculum cellular meningioma have a bilateral involvement of the optic nerve, while the clinodal meningioma has got a unilateral involvement of the, so unilateral visual loss, always we suspect this clinodal meningioma or medial spinal meningioma. The third type meningioma, in second type, there is a good arachnoid plane between the, though they grow to a very large size, but the arachnoid separates the tumor from the very important structures like third nerve, like carotid artery and the optic nerve. Type 3 tumor usually arise near the optic foramen, And these are the tumors very early, they involve the vision, and they very small size. They present as a, these tumors are very small because they present very early because of the vision involvement. And these are the diagrams showing how this arise and can involve the optic canal and give compression on the optic nerve. There was later on some modification in these three types of Lamyoplasty classification. This Pamir et al. Has divided these three groups into ABC. Group 1 ABC depending on the size of the tumor. If it is 2 centimeters suprasellar extension, it is group A. 2 to 4 centimeter is group B, and more than 4 centimeter is group 3. Similarly, in group 2 and group 3 of Lamyoplasty, they have A, B, and C depending on the size of the tumor. So these tumors, how they arise from the clinoid process, and they extend upward from the dura of cavernous sinus, clinoid, and the interparthenoid. And this is the basic about the clinoid meningioma. They involve the optic nerve, sometimes optic crest when they grow large. ACNS branches right from the origin of the carotid, which entry into the cisternal segment, and its branches right through from the carotid supraclinoid ICA to the bifurcation of the carotid, midcellular arteries, and the intercellular arteries. Usually the bone is not involved except the enteroclinoid process. So this is the classically a clinoid meningioma described, and you can see the hyperostosis of the tip of the clinoid, which is very classical to label these tumors as a clinoidal meningioma. And if they grow downwards, they involve the cavernous sinus. This is a classical example arising from the clinoid process, going upward and down some part of the tumor which is grown inside the cavernous sinus. And some authors have described conceptually these tumors, the three different tumors in close proximity: a cisternal portion, a cavernous or carotid portion, or an optic canal portion, sometime when it grows inside the optic canal. The resectability criteria for the clinoidal meningioma all depends on the so many factors: its relation with the internal carotid artery, its displacement or its encasement, or whether tumor is arising as a grade 1 classification of the Lamyoplasty, where it involves the carotid wall, or if it is causing stenosis, or maybe bilateral involvement, tumor extension inside the cavernous sinus, invasion of the optic canal. In that case, you have to drill the optic canal to remove the tumor. Pre-operative visual status: if visual status is poor, that nerve handling is not you can't handle much the tumor, amount of the tumor volume, or intact arachnoid plane between the tumor and neurovascular structures. These factors will decide whether tumor can be resected completely, safely, without producing any morbidity or mortality. Resectability and results: also, the complete tumor resection is possible if not adherent to ICA, if there is no extension of tumor inside the cavernous sinus. And in these cases, visual improvement can be expected in 2/3 of the clinoidal if the patient has got impaired vision. But if he is not blind, usually we can expect the vision will improve with careful dissection of the tumor from these vital structures, particularly the optic nerve. These are the various approaches are being used to detect these tumors. Our preferred approaches used to be pterional, and now it is frontolateral. The frontolateral approach is a very good approach. It is, you can say, it is some kind of modification, a smaller pterional, where you don't expose the temporal side very much, expose minimal cilium fissure, which you can open immediately, and you can access this tumor. This gives a very, very good area of exposure. And if tumors are large, we can go for the frontotemporal, or some kind of osteotomies can be done, or better cranial approaches, so-called keyhole approaches. And some kind of skull-based techniques has been described, like extraocular drilling of the clinoidectomy, or false ligament, and optic nerve sheath opening later on once you open the dura. So here again, the surgical goals remain the same. Aggressively, tumor can be removed, and it should be removed wherever possible. And you must avoid intraoperative morbidities. That comes from particularly from the vessels around. It is very, very important to preserve this vessel. These are very major vessels, carotid artery and its branches, middle cerebral artery, sometimes MCA branches, MCA perforators are very, very adherent to the tumor capsule and difficult to separate sometimes. And in that exercise, sometimes you may have some kind of problems with the vessels. You can injure the vessels, and you can have some bleeding, and you can develop post-operative neurological deficits. And the goal is improvement of the visual function. And these are the challenges I discuss always. This IC and optic nerve is the most two important two things which in this meningioma section is very, very important. And sometimes tumor when extend into the cavernous sinus. Some series they have quoted this about 30, 40, 60% of tumors they grow inside the cavernous sinus, but some series cavernous sinus extension is very, very minimal. So these are the steps of surgery. You can do good anatomy, and you can drill the sphenoid wing ready, or if required, you can do osteotomies. Sphenoid wing drilling, canal D-roof you can do extradurally also. After opening the dura, you have to open cilium fissure widely, and these two things goes simultaneously: devascularization and decompression. You can reduce the size of the tumor. At the same time, you can devascularize by coagulating the basal dura, by coagulating the attachment of the tumor, and decompression will help in reducing the pressure over the surrounding structures. When it is very good decompression has been achieved, you can dissect the capsule, and you can treat the attachment, and you can remove the involved bone. This is one example. This is a very recently operated a tumor of this patient presented with the unilateral visual loss, and you see it is extending upwards right from here. So this is a classical crinoidal meningioma. Like medial sphenoid meningioma, when they grow towards the crinoidal meningioma. When meningioma extends from the climate process, they grow upward. So this is a classical patient has got a unilateral visual loss and headache symptoms. And this patient we had operated by frontolateral approach. This is actually the post-op MRI, which shows a complete excision of the tumor. A small video I will show. So once you open this here, you see visibly here only this much area which is involved, not like whole wing right from here. So this is optic nerve which is pushed medially here. He is getting tumor getting some supply from the CF floor, and this is area lateral to the clinoid process area where this tentorium gets attached here. Always you protect your bipolar coagulation with the cotton patty here. So here now question comes, you have to see some of the important structures so that you can start dissecting. So which way to go? So easiest is you go distally and see some of the branches and follow those branches, and you can dissect arachnoid sharply, and you can separate the tumor. So this is linear process. This little longer video I would like to show to the young neurosurgeons. So once that is over, then this is external portion you should decompress well, before you start separating from the surrounding structures. So this frontal approach is very satisfying to remove these tumors, and you have adequate exposure of all the structures around. And you see here the optic nerve, which is pushed medially, and in a moment will separate it sharply from the surrounding structures, from the tumor. There is some pallor of the optic nerve, but you see the vascularity is preserved, good vessel, and this is the most important arachnoid over there, which carrying the vessel to the optic apparatus that needs to be preserved to have a good visual outcome in these patients. And this is on the undersurface of the optic nerve. Now, just cutting the falciform ligament so that you can have more area to look for any tumor there under the inferior-medial aspect of the optic nerve. There is some tumor there, you can see. There is some tumor. Now, once it is decompressed, you see the optic nerve, which was seen compressed very much, and now you see the nerve caliber once tumor pressure is gone. Slowly separating from the carotid. Now the remaining part of the tumor in the system being separated. Now carotid is free. This is tentorium here. This is planoid process, and this is the dorsum, and this is pituitary stalk, and this is at end. You can see optic nerve is very nicely decompressed. This is stalk and there. This dorsum. To complete this, we will go for the clinoid removal. We make the dural flap like this, and we drill out the bone of the clinoid. So you see here, it is very discrete. It is not a very large attachment of the sphenoid wing. Clinoid tip is being removed. Now that clinoid dura is being cut, and this is at end. I think this is complete excision. You can call it as a grade 1 excision of the clinoid meningioma, and all the structures are free. This other patient who has been operated long back. A patient came with a blind in the left eye, and this was when I was in Shichitra there, and this patient was operated on the frontotemporal craniotomy. after adequate decompression, tumor capsule is being separated from the surrounding structures. And in the similar way, this is at the end, and we go for the clinoidal attachment area, excise, and we drill the clinoid also. And this patient, if you see the vision improvement, you can see here patient was blind here, and subsequent follow-up post-operatively, patient has improved complete in vision in the left eye. So that is important of a meticulous technique and minimal handling of the optic nerve, preserving its vascularity, and so that you can have good visual outcome. Another example, huge meningioma, but the very discrete assessment for the clinoid process. This is post-operative scan, which shows complete excision of tumor. And this patient also had a very good visual outcome. On the left side, there was no other side eye also was involved, but then subsequently after surgery, there is an improvement in the vision. These are some more examples, pre and post-operative complete excision of tumor. This is a type 3 variant of the Lamyoplasty, and this tumor is very small, but there was a significant involvement of the vision, and this tumor was completely removed. Another huge meningioma attached to the clinoid process. This is post-operative CT scan showing complete excision. Sometimes tumors are very, very large and sometimes very adherent to the surrounding structure. And this patient, we had operated in 2 stages. We have stopped here, and this part was remaining, and in the second stage, we have removed this tumor completely. Sometimes the staging also is good to achieve good excision and reduce the damage to the surrounding structures. So this is one patient we have operated in 2 stages. This is another patient who had a clinoidal meningioma, and there was an aneurysm present there from the dorsal medial wall of the ophthalmic segment. And this tumor was removed completely, and the aneurysm was also taken. Sometimes you can have meningioma in the orbit, optic sheath meningioma, and there is a clinoidal meningioma, and this was. So in conclusion, majority of the clinoidal meningioma can be removed completely, and despite the large size and intimate relation to critical vascular structures. An improvement in vision is expected if preoperatively if patient is not blind. So this is the diaphragm. This was the tumor arising from the diaphragm, and we had operated through the transcranial route, and tumor was excised, and only except the part which was superiorly and anteriorly, which was remained. And we advised for the second time surgery to remove this tumor transcranial route, but patient did not agree. But patient had a good improvement in the vision. So coming to the visual outcome in clinoidal meningioma, we had a pre-operative visual involvement in 16 patients, and the post-operative patient, 9 patients improved, that is about 56%, and 7 patients remained static. Out of diaphragm cellular meningioma, there was only 1 patient, and that patient improved. So these are some of the factors which can influence the visual outcome. This is important is the pre-operative visual loss. And coming to tumor factor, if tumor is very soft with a firm capsule, and you must adequately decompress before starting the separation of the capsule from the surrounding structure, with minimal handling of the very vital important structure for the visual improvement, that is optic nerve. The intraoperative factors, if nerve has got a good caliber and vascularity, these patients will implement in the vision. Optic canal unroofing has to be done if tumor is extending inside the optic canal, and avoidance of high power coagulation. So, into the conclusion for the perioptic meningioma, these meningiomas involving the optic nerves need a special consideration. The preoperative visual loss is important predictor for the post-operative visual outcome, and a good visual outcome is expected. End of my talk. Thank you very much for your kind attention. I thank you, ACNS, and I thank everybody, chairperson and moderator. Thank you.
So thank you very much for your nice lecture. And we showed that, nice summarized for that pretty much the educative. And also we can see that a good surgical video. And also he presented us a little bit complicated cases, but he had an excellent outcome from his surgery. So this lecture is now open to the questions. So anybody come here?
Can I put some comment? Excellent.
Yeah, go ahead, please.
Excellent presentation, Rajneesh. I loved listening to you. I have listened to this.
Thank you, sir.
What a great lecture. And he was a faculty with me at Chitra Tirunal Institute, and some of the cases he showed he had operated there. Great surgeon. He's the president of Skull-Base Surgery Society of India. But my question, 2-3 comments and questions and your views I want. One thing about tuberculum meningiomas. Tuberculum meningiomas now, say you are basically microscopic surgeon, but now extended endoscopic approaches. There was a study from San Francisco group with Kappa Bianco group from Italy, and they compared this outcome between endoscopic surgery and transcranial surgery. One in San Francisco University there in California, University of California in San Francisco, and Kappa Bianco. They have found that they have formed a scoring system for tuberculum meningioma. It is, adverse factors where extension laterally across the optic nerve prior surgery.
Absolutely.
And of carotid. If these things are there, then either you operate transcranial or you operate transsphenoidal. The outcome remains same. But, they found surprisingly invasion of the optic canal and also size of the tumor had nothing to do with transcranial or endoscopic surgery. So
yes, sir.
What ultimately the conclusion is, the improperly selected cases, they have a scoring system. The lesser the score, better the visual outcome, and more what they have found in properly selected cases. With equal score, so they found that the extent of gross total removal is same for both the group, but on long-term follow-up, they have found that the recurrence is more for transcranial surgery. That is one thing. And so this is just because you covered everything about transcranial. This is just to tell endoscopy also is coming in a big way. And the second question to you is about clinoidal meningioma. So the more we read, more confusing it is regarding terminology.
Absolutely. Absolutely.
You correctly told, the clinoidal meningioma is not synonymous with medial sphenoiding meningioma as properly coined by Professor Pamir. And Professor Almarti's classification still people quote, it is 32 years old now. So recently a classification has come from China in Frontiers of Oncology by Zhu Tao. Excellent classification, superior surface, medial surface to lateral surface, and the tip of clinoid. All four are clinoidal. He classified it into 5 tumors, all are different. What a beautiful article he has written in Frontiers of Oncology, and with meningeal architecture and clinical data. But this is okay. But what you have told, my only question to you is, you highlighted transcranial. Many people advocate extradural clinoidectomy, optic canal unroofing, and decompressing the optic canal and cutting the falciform fold, everything, which you told intradurally. Many people do extradurally decompress the optic nerve, everything, and it controls some vascular control also. You can have extradural do. You suggest that for these meningiomas, clinoidal meningioma, extradural.
Yeah, there are many reports regarding the extradural clinoid relief and optic canal decompression. And they have found a very good result, like Lee et al. And all. There is a paper that they have got a. There's an advantage that you can define the nerve extradurally, and you are able to hear me? No.
Yeah, I'm hearing you very well.
So extradurally, you can define it very well. And when you open the dura, nerve is already, very well defined. But there are different views that with the large tumor, tumor is packed, optic canal is packed with the tumor, drilling the heat and the surgical manipulation. Whatever the disease nerve, that can get more damage because of that. So what I do is go intradurally, decompress some part of the tumor. So the pressure is released from the nerve, and then you can do whatever manipulation you want to do. So you can do intradural drilling later on if tumor is extending inside the canal.
You are correct. Only counter pressure against the falciform fold. While you drill, you do extradural clinoidectomy can be detrimental for vision. I agree. And one more point which I didn't tell you, Professor Pamir has correctly told that the tumor which extends to the cavernous sinus, which he calls sphenocavernosus. They are medial sphenoid. They push the temporal lobe from anterior and medially.
Anteromedially,
Pure they won't have anything to do with temporal lobe. And usually they don't involve the cavernous sinus. This is something, as I told you, more you read about clinoidal, more. I think Professor Koto can help us diffuse this confusion.
Okay, so actually that's your surgery is pretty much excellent, and I hope that everybody can understanding that what's your purpose of the surgery. But I just want to have the one question for you, since that you're always approaching from the right side, and little bit small craniotomy and subfrontal approach, and you can get a good surgical view from that. But I just wondering that do you have any a patient who have that smell disorder? I mean anosmia after the surgery. Could you give me some idea for that?
That is very less with the unilateral approach.
Okay, thank you about that.
Anosmia is very less with the unilateral approach. You can get more commonly in the bilateral bifrontal craniotomy. And
I believe so.
And even the transphenoidal approach, sometimes you lose because a lot of dissection in the nose, you may lose the olfaction. So the olfaction is at least one side if it goes, other side it is preserved with the unilateral approach. So we prefer this unilateral frontolateral approach, and which gives a very good access to the tumor.
Okay, great. So since that your surgical field is pretty much clear, so I just wondering that it's to support it about the olfactory nerves. Thank you about this. So do you have any the others have any question for Dr. Kachra?
So far none. I think it's time we can conclude. You may say your concluding remarks.
Okay, so you may know that wonderful surgical video is also educating a lot of things from us. So thank you for a nice lecture, and hopefully we could use that your idea and get the excellent outcome from that. Thank you for your lecture again.
Thank you. Thank you very much.
That was a wonderful session, Professor Rajneesh Kachra and Professor Akide Kondo. I'll close this officially now on behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato. I would like to thank both the speakers of today, Professor Rajneesh Kachra and Professor Prabin Shrestha, as well as the chairs, Professor Akide Kondo and Professor Sajesh Menon, for their time and support for the ACNS webinars. I would like to express my sincere thanks to Professor Shubin for broadcasting this on the WeChat channel. And as of now, we have around 560 people who have joined us live on different streaming platforms. A special thanks to my co-host Liubun Singh for joining in me today. So until we all meet on next Saturday, it is bye-bye from all of us. Thank you very much.